Welcome to ASRS's Journal of VitreoRetinal Diseases Authors Forum. I'm your host, Dr. Timothy Murray, Editor-in-Chief of JVRD. On each episode of the JVRD Authors Forum, I will interview innovative retinal researchers on their studies featured only in JVRD and how these studies will impact our patients' care in our clinics. Tune in to hear directly from investigators about the clinical implications of the newest and highest quality research in the field of retina. Welcome to JVRD's Author Forum podcast. I'm Dr. Timothy Murray, Editor-in-Chief, and I'm joined by my friend and colleague, Dr. Albert Lee of VitreoRetinal Consultants of New York. He's a clinical associate professor of ophthalmology at the Zucker School of Medicine in Hempstead, New York. He's going to talk about his paper, Multiple Successive Branch Retinal Artery Occlusions in a Patient with Antiphospholipid Syndrome Despite Anticoagulation. Welcome, Dr. Lee.
Dr. Murray, thank you so much for the opportunity.
So it's a pleasure to have you. You know, I think this is one of the things that we all strive to better understand. So tell me what first drew your attention to this patient.
This was one of those patients that came in as a new patient for a routine eye exam. And of course, when you dilate them, your heart sinks when you see that area of retinal whitening that's concerning for branch retinal artery occlusion. So certainly I started to dig a little bit more, and she had triple negative antiphospholipid syndrome. And we know that antiphospholipid syndrome is certainly a risk factor for developing retinal artery occlusions. But one of the reasons why this case stuck out in my mind is after ordering the appropriate workup, reaching out to her rheumatologist, who is responsible for managing her antiphospholipid syndrome, she came back a month later and developed another retinal artery occlusion. And that was demonstrated beautifully on fluorescein angiography. Unfortunately, I found out later that just a short time after that, she was hospitalized and passed away. And this is not the typical course that you think of when you see a patient with retinal artery occlusion. This prompted me to want to understand a little bit more about the presentation of retinal artery occlusions. Is this something common? And why did this happen to this patient?
Well, you know, I think that you've really identified some of the keys here, which is multiple arterial occlusions. I think that I get excited when I see a patient with a single branch retinal artery occlusion, as you did, and I differentiate artery to branch vein occlusion, and then of course the impact is often defined by where that occlusion involves functional visual areas, and because often it's one eye. Sometimes patients don't have symptoms, like your patient came in for a routine exam.
Right.
But I think that any patient that has an artery occlusion really requires us to bring some clinical acumen to their evaluation. So in this case, you knew already that there was an antiphospholipid syndrome, correct?
Correct.
Now, did it bother you that knowing that and knowing that the patient was, quote, on treatment, that they, in spite of that treatment, developed an arterial occlusion? What's your trigger to go to that next step?
It certainly is bothersome, but as we went through the literature, it was interesting to see that the thromboses that you get in antiphospholipid syndrome tend to be large vessel, or at least that's what's described, the large vessel occlusions such as myocardial infarctions or strokes or pulmonary emboli, which are what lead to death in these patients. But microvascular thromboses, such as what we would see in the retinal vasculature, are not as well characterized, and the literature seems to show that even with anticoagulation, it's not effective in preventing these small vessel occlusions, such as what we would find in the retinal arterioles.
Okay, so your patient is on anticoagulation alone. What would you have thought if your patient had a single event and then another independent arterial occlusion? What would be your management? Is that a from my office to the emergency room at a stroke center, or is that from my office back to the managing cardiologist or hem-onc person or rheumatoid expert?
I mean, I think we've benefited from the neurology literature in the past 10 years, which has shown us that anyone with retinal ischemia, uh, there's like a 25% risk of seeing abnormalities on diffusion weighted imaging, or in other words, having a stroke. Um, so certainly without any other history, especially if it's acute, I would send them to a stroke emergency department. In our department, will also work very closely with interventional neuroradiology, and if they present in an appropriate time window, less than 12 to 24 hours, they're able to intervene in the appropriate patients. But in this case, because there was a known risk factor of being having antiphospholipid syndrome, I thought it was prudent to interact with the rheumatologist and try and figure out what would the next steps be, because it's a more unique situation where we know what the inciting factor is.
So one of the things we're seeing in a lot of our offices is a move away from fluorescein angiography evaluation to non-invasive vascular assessment. Do you think that fluorescein is necessary, or are there alternative ways to image a patient like this that can still give you the information you need to make the clinical diagnosis?
Certainly, I feel like I agree that the old school fluorescein angiogram still has a role in our clinic. It certainly is still the gold standard, and it beautifully demonstrates when there is a retinal arterial occlusion. Certainly, there are other modalities such as inner retinal hyperreflectivity on OCT that is suggestive of a retinal arterial occlusion. But I think that especially when there's no symptoms or it's not a classical presentation, that's where fluorescein angiography comes in handy, and it certainly did in this case.
And so many people now, if they're going to get fluorescein, are getting ultra wide field fluorescein.
Right,
Some people are looking for swept source OCT changes to delineate the area of the arterial occlusion. And some people are using OCTA, in this case, really not flow directed because there's a flow void here.
right.
Um, so I think that the imaging in yours was beautiful. I think the imaging is still important, as you've suggested, in giving us insight in what's going on. And one of the things I focus on often with the fellows is look at the other eye first. So in
Mm.
this case, you didn't know which the other eye was because the patient's asymptomatic. But if the patient had come in symptomatic in the right eye, I say look at the left eye and have an open mind to make sure you're not missing anything in that fellow eye.
Absolutely. I think that sometimes we're just there's tunnel vision that we're worried about the eye that's having symptoms and we miss other things. And it could be a bilateral presentation of a disease.
And then how heartbreaking that you have a patient that presents to you with an asymptomatic ophthalmic finding and then dies in a relatively short interval of follow-up. I always find that tugs at my heart a little bit.
It was really difficult. I think it was, I can say that we were able to obtain permission from the patient's husband to publish this case he realized that it was important to get the word out. And he was a fierce advocate for his late wife. And the only heartening thing, I guess, was I heard about this through one of my referring doctors who interacted with them in a sports team, and she just called me and told me about the patient's passing, and that they were very grateful that I was able to help with the eye findings that she presented with.
Well, I think that in the real world that you and I deal with in our clinics every day, patients can be so appreciative of assistance that we feel we haven't really been able to give them what we would want to give them. So I give you a compliment on having the patient appreciate the care that you brought to the patient, even in this ultimately, mortal disease.
Thank you. I think we would have wanted to try to do something to try to treat the root cause, but unfortunately, this was a presentation of catastrophic antiphospholipid syndrome, and unfortunately, the mortality is quite high.
And I do think one of the things to emphasize is how significant this condition is in sort of life expectancy, and that the eyes are a small part of this. I wonder always, because we're so blessed in ophthalmology and in retina in particular to look at small vessels directly. I always feel like it's a privilege. So
Absolutely.
when people tell me that they don't really see small vessel disease, I'm always like, well, of course you don't, but we do. And
Right.
I think that's one of the unique things about our vitreoretinal specialty is being able to look at disease in a very unique way.
I always tell patients that it's a privilege that we have as retina specialists to be able to visualize the vasculature in vivo without needing to cut the eye open or cut any organ for that matter open, and we're able to describe disease as it presents.
Well, I'd like to thank you, Dr. Lee, for bringing this fascinating yet sad case to us, but it does broaden our understanding of the importance of collaborative care and the impact of patients with broad antiphospholipid syndrome, even with current aggressive management. So thank you for an excellent case report.
Thank you so much, Dr. Murray.
Thanks for tuning in to the JVRD Authors Forum. You can watch and listen to more episodes on the ASRS YouTube channel and on popular podcast directories, including Apple Podcasts and Spotify. Visit www.asrs.org/JVRD forum on the ASRS website to learn more. See you soon.